And I want to kind of start dialing things in for that. So, how about this one? The precentral gyrus is responsible for which of the following? Integration of sight, sound, and taste, controlling your emotions, assisting in memory acquisition, coordinating the rate and timing of breathing, or directing motor movements. Motor movements is pre, so E, and if it was post-central gyrus, the right answer would be maybe something on the list. Well, actually, it could be. What would the post-central gyrus would be A, sensory information, right? How about this one? Okay, so here's the kind of way I like to ask, how do the different centers work in the brain? 67-year-old woman experiences a stroke to her right temporal lobe. Which of the following will most likely result from this permanent damage? So it's not reversible, I just told you that. Loss of vision in the left eye. Loss of vision in the right eye. Loss of gustation on the right side. Gustation is what? Taste. Loss of gustation on the left side. Loss of hearing in the right ear. Loss of hearing in the left ear. Two of these. Now you don't have G options on the Scantron, but I'm just trying to get you ready. What do you guys, what's the right answer here? Stroke to the right temporal lobe. How many of you like A, B, C, D, E, F, G? Okay, so the F and the G's have it, right? So F, loss of hearing in the left ear. If it's stroke on the right hemisphere, it would affect the left ear. I would agree. But what about taste on the left side? It would also do that too, wouldn't it? So it should be G, two of these. Okay. How about this? Because of a brain lesion, a patient never feels full, but eats so much that she now weighs nearly 600 pounds. The lesions are most likely, that should be are most likely, in her where? A, hypothalamus, B, amygdala, C, hippocampus, D, basal nuclei, or E, pons. A, hippocampus, why? I'm sorry, A, hypothalamus, why? Hunger, thirst, water balance, pleasure, sexual desire, rage, all of these innate humanistic activities are part of the hypothalamus. Okay. You should definitely know this list. Right? So the idea in lecture, again, let me repeat, is to focus all of your studying so that you have the ability to really hone in on what are going to be possibly test questions on the exam. The reading, the assignments online that are all open book, open notes, all of these things expose you to a broad base within this class. And then the lecture, even if I get off tangent, you're in a broad base and then we kind of hone things down. So this is my attempt to really help you focus. Yes, there will be a study guide, okay? And we'll get that out by what? Thursday evening, okay? We'll talk about SI sessions on Thursday. We'll announce that. They're always posted on BB Learn. But you really should be able to label all of these structures, okay? If you printed out your sheet, you want to do this right now? You want to try it? Yeah. Let's just try it. Why don't you just give it a whirl? 1, 2, 3, 4, 5, 6, 7, 8. And just write down next to each number. You can put it on a piece of paper. If you didn't print it out, you can just write 1 through 8 on a sheet of paper and answer it right now. Okay? If you printed it out, don't look at the next slide. Just do a self-test. A week before, let's take inventory. How are you doing? How much do you need to study this stuff? A lot. I heard that. Okay, that's fair. Better to know today versus Sunday morning at 4:30 in the afternoon when you wake up. What's that? What's 7? Oh, you'll see in a second. 1, 2, 3, 4, 5, 6, 7, 8. You guys ready? Oh, 9. Sorry, there's 9. Yeah. Who's still working? Okay, fine. That's fine. Take your time. Okay, you want to do a little self-quiz and see if you grade your own work. Okay? 7 is the primary auditory cortex. Okay, we're seeing the left side of the brain, correct? We're seeing the left side of the brain, correct? Yes. It's better to say correct versus right. We're seeing the left side of the brain, right? Correct. So, over here at 1, our visual associative cortex. 2, sensory associative cortex. Again, sensory, towards the back. Somatosensory cortex, number 3. This is also referred to as our post-central gyrus. Precentral gyrus, the motor cortex. The frontal lobe, that should be easy. Here's Broca's area. Primary auditory cortex. Here's Wernicke's area in the parietal lobe, towards the back. And our cerebellum, number 9. How'd you guys do? Pretty good? How many are feeling pretty good about how you did? How many are going to be studying? Okay, awesome. Sweet. I would also know the functions of these, what they do. My favorite way of asking these questions is if you have damage to one of the areas, what happens? Okay? You guys can totally take pictures of the screen, that's fine. But you have all these slides, they're all on BB Learning, so you can use either mode. Alright, interior brain parts that we covered. I'm reviewing what we've covered. Right? All of these lists, some of them we covered, actually all of these we covered today. Right? So these are all fair game. If you're a flashcard person, this is a great list of flashcards, is these first few slides. Okay? Alright, I want to introduce the spinal cord in our remaining time. And then we'll come back to it. This is kind of an exciting lecture because we get to talk about some other types of clinical issues like herniated discs. And we get to talk about whiplash injury. Okay? We'll talk about like hunchback disease. It's at the thoracic vertebrae. So we're still within the central nervous system, and this is the spinal cord. And we see that the functions of the spinal cord are really to serve as an integration center between the periphery, the peripheral nervous system, and the central nervous system. So the spinal cord comes down, and it is out there near the periphery, and it allows for sensory neurons to come in on the posterior aspect, send information up the spinal column to the brain. It processes as it moves forward or into the frontal lobe, and then it sends a signal back down to the spinal cord and has activity out the front to cause motor activity and a response. You've got reflex coordination that happens here. We control reflexes like when we touch a hot stove and we withdraw. When we have a sharp object that induces a pain response. Many times you've noticed that you withdraw faster than you actually sense the pain. Because the reflex is happening at the local level, involving the spinal cord, and the sensory information comes in, and the motor information comes right back out that spinal segment. And at the same time, there's an interneuron that sends information up to the brain so that you can interpret what it is that you felt. Right? And sometimes you do that, and you feel something, and you withdraw, and you realize, oh, that wasn't hot. I just thought it was going to be. Have you ever had that happen? Right? And you've already done the action, and then the thought is, that was kind of silly. It's not even on. Right? So how does that work? Because the spinal cord is giving you this reflex capability at a local level, and that signal is circulating quicker than the signal that goes up to the brain and comes, hits the cortex and says, it's not even hot. And then you say, it must not be on. I thought I left it on. Who turned it off, right? All these little things are moving around in your brain, and you've already withdrawn away from that hot, theoretically, that hot stove. Yeah?
So what's going on with those people who have that accuracy where they can't sense that kind of stuff like that, kind of pain or...
So we're going to talk about pain after the exam. And so I would encourage you to remember to bring that up. But there are specific receptors known as nociceptors that are pain receptors. And in certain individuals, they're either less developed, absent, or the neurotransmitters that are sent are non-existent. Okay? All right, so the locomotion. The locomotion that allows us to control our activity, right? We do not have to naturally think once we've learned how to walk, right? Now we can walk without even thinking. Some of you can walk and chew gum. Many of you cannot walk and text, because I've seen it happen. Okay? But I'm sure we'll get there as a species. We've evolved to be able to master gum chewing and walking, and I'm sure soon we'll be able to text and walk just fine. Okay? But these central pattern generators that are located within the spinal cord allow us this ability to do these routine activities without having cerebral innervation or cerebral control. If we look at the way it's organized, the way that the spinal cord is organized, here's the anterior aspect, here's our posterior aspect. We have meningeal layers just like we saw in the brain. So we have the same spaces. We have the dura on the superficial most portion. We have the arachnoid in the middle, and then we have the pia that actually is the most deep layer. And the subarachnoid space is where that cerebrospinal fluid flows, and you can actually see that represented by the blue fluid. Okay? The epidural space is where we deliver narcotics to pregnant women before they deliver, and we've affectionately referred to it as an epidural. Okay? But it's referring to the space at which you insert the needle so to deliver the narcotics to numb those nociceptors just in that distal location. So understanding the difference between the epidural space and the subarachnoid space, you would not want to put it into the subarachnoid space. You wouldn't have the same analgesic effect, which is the pain-relieving effect. Okay? We'll pick it up here on Thursday for our last lecture.